Now we are going to discuss pathology of breast. But before going into the detail of the various lesions of the breast, I think it is important to discuss briefly various histological features of the breast. The breast is composed of both epithelial and stromal components. Now, if you remember the rule of two, it will be little easier to remember the histology of breast. That is, two types of epithelial cells, two types of stroma, and two types of structures. Now, two types of epithelial cells, that is luminal cells, myoepithelial cells, two types of stroma, interlobular stroma and intralobular stroma, two types of structures, large ducts and terminal ductal lobular unit. The ductolobular system is composed of a dual layer of epithelia which is resting on a basement membrane and surrounded by stroma. A number of benign metaplastic changes may be seen in the luminal cells and myoepithelial cells due to injury, hormonal influences, or many other unknown factors. I'll discuss two important metaplastic changes in detail. Squamous metaplasia is seen in response to injury, inflammation. Rare squamous carcinoma arise from areas of squamous metaplasia in cysts, and the presence of spindle epithelial cell population in the stroma is mostly diagnostic of carcinoma. Apocrine metaplasia, a very common change seen in the cells lining cystic spaces and in papillomas. It resembles apocrine sweat glands. Apocrine cells also express the androgen receptors and show immunoreactivity for HER2. When there is mixed apocrine and non-apocrine population of cells, it favors benign lesion. The nuclei of these apocrine cells are large and round with prominent single nucleolus. The cytoplasm is abundant and eosinophilic. Red cytoplasmic granules are often seen, and there are apocrine snouts are commonly present. Then there is clear cell change, then columnar cell change, and one thing I must mention that luminal cells are tall columnar in shape rather than being cuboidal. If more than one cell layer is present, it is called columnar cell hyperplasia. Then Paneth cell-like change is also seen. Now, few words about luminal cells. They form innermost layer of lining in ducts and acini. Luminal cells, which are in the terminal ductal lobular units, produce milk, and the cells which are lining the larger ducts do not undergo lactational change or produce milk. These cells are cuboidal to columnar in shape. Nuclei are small, round to oval in shape, usually have inconspicuous nucleoli. These cells have moderate amount of eosinophilic cytoplasm. They usually express luminal low molecular weight keratins, that is 7, 8, 18 and 19. Some of these cells express estrogen and progesterone receptors at a particular time. These hormone receptors are not expressed in the normal proliferating luminal cells. Receptor cells are present in both large duct system and terminal ductal lobular units. These cells express E-cadherin and other catenins. Some of the luminal cells express mammaglobin or gross cystic disease fluid protein 15. These cells are thought to be the precursors for majority of the breast tumors. Myoepithelial cells, they form the outermost layer between the luminal cells and the basement membrane. They are forming contractile meshwork and do not cover the entire basement membrane. In cross section, the myoepithelial cells layer is incomplete. These myoepithelial cells have multiple functions. They help to produce and maintain basement membrane. The lesions of myoepithelial cells are most often associated with matrix production. They aid in luminal cell polarity. They inhibit angiogenesis. They contract for ejection of milk during breastfeeding. They are often flat with small and round nuclei. Their cytoplasm can be abundant and clear. With the age, these cells become prominent and spindled in shape. They usually express high molecular weight basal keratins. They also express luminal keratins. They express contractile proteins, that is smooth muscle actin, calponin, smooth muscle myosin, heavy chain. They also express CD10, P cadherin, S100, mepsin. Now, very important point, they do not express hormone receptors. Myoepithelial cells, which are associated with carcinoma in situ, may diminish in number and become displaced from the basement membrane. These cells often fail to express some myoepithelial cell markers. The complete loss of myoepithelial cell is a diagnostic feature to help to recognize invasive carcinoma. Again, a very important point. May be precursors of some hormone receptors, negative carcinomas. Basal types are used to describe carcinomas that may arise from myoepithelial cells or myoepithelial-like cells. Many of these carcinomas express proteins which are found in the myoepithelial cells. Now, a few words about basement membrane. It surrounds mammary ducts, ductules and acini. It consists of type 4 collagen and laminin. It is separating the ductal system from the surrounding stroma. If the tumor cells in ductal carcinoma in situ pass through the basement membrane and myoepithelial layer, it is then defined as invasive carcinoma, a very important point. There are some types of invasive carcinomas in which basement membrane material can be demonstrated by special stains. Now, a few words about mammary stroma. The stroma composition of breast depends upon age, menstrual status, pregnancy history and lactation. It is composed of varying amount of fibrous connective tissue and adipose tissue. Interlobular stroma surrounds large ducts and terminal duct lobular units, denser, more collagenous than intralobular connective tissue. It is responsible for majority of breast volume. The increase in size of breast at puberty is primarily due to increase in interlobular stroma. Hormonal changes can influence this stroma. The cellular component of stroma include fibroblast, myofibroblasts, adipocytes, blood and lymphatic vessels. Majority of the fibroblasts and myofibroblasts are CD34 positive. However, some of myofibroblasts are ER and PR positive. In the interlobular stroma, there are large hyperchromatic multinucleated stromal cells are seen, which are due to degenerative changes. A number of lesions that can occur in and outside of breast arise from this stroma. The lesions in breast and other sites like lipoma, angiolipoma, hemangioma, nodular fasciitis, fibromatosis. The lesions most common in breast, myofibroblastoma and angiosarcoma. A very important viva question. Pseudoangiomatous stromal hyperplasia, that is called PASH, is present in the breast. Now, a few words about intralobular stroma. It surrounds and supports acini of terminal ductal lobular unit. It has a loose and more cellular appearance when compared with interlobular stroma. Scattered lymphocytes and plasma cells can be seen. It can be myxoid in appearance. The lesions which arise from this stroma are specific to breast and are biphasic. Very important point. Hyperplasias are due to increase in the growth of both stroma and epithelium. Neoplasias are due to proliferation of clonal stromal population that stimulates growth of non-clonal epithelium, for example, fibroadenomas and phylloids tumor. Now, before going into the duct system of the breast, there are a few photographs. The first photograph shows acinus marked with blue arrow, stained with hematoxylin and eosin. The other photograph shows myoepithelial cells by immunohistochemistry, and you can well appreciate it surrounds the luminal cells. Then a larger view of acinus. Towards the lumen, there are luminal epithelial cells marked with yellow arrow. Beneath this, there are myoepithelial cells marked with red arrow, and then basement membrane, which is marked with green arrow. Now there is a photograph which shows lobule microscopically, and it is marked with blue circle. Then there is a photograph in which lobule is marked with blue, whereas it also shows an acinus which is marked with black circle. Then there is another photograph which shows microscopic features of lobule, and it is marked with red arrow showing intralobular loose stroma. Another photograph showing two lobules and interlobular fibrous stroma, which is marked with red arrow. Now, a few words about large duct system. About 15 to 20 major duct systems empty at nipple. There are additional smaller ductal systems open onto the areola. These ducts ramify until they form terminal ductal lobular units. The ductal systems vary considerably in size and extent, which often overlap. They rarely confine to a single quadrant. Their size and extent vary greatly in different individuals. Anastomosis between ductal system may be present. Now, significance for breast cancers. Ductal carcinoma in situ, that is DCIS, is clonal proliferation which involves single duct system. Distribution of ductal carcinoma in situ, that is DCIS, usually follows ductal system. However, multiple ductal systems could be involved. Now, a few words about lobules. They are formed when terminal duct branches into multiple rounded acini. They are the functional units of breast for milk production. Lobulocentric architecture is important, which differentiate benign lesions that maintain this architecture from malignant lesions where this architecture is lost. A very important point. Terminal ductal lobular unit can unfold and with coalescence of acini to form structures resembling ducts. 50% of all glandular tissue located in the upper outer quadrant. Again, an important point. Majority of the breast lesions arise from the terminal duct lobular unit. Now, this is a photograph showing a diagram in which there are ductules and there is lobular formation. There is intralobular terminal duct, extralobular terminal duct, and they form terminal duct lobular unit, briefly written as TDLU, which is terminal duct lobular unit. Now, this is the photograph which shows terminal duct lobular unit and lesions arise from them. Terminal duct lobular unit, the lesions which arise are cyst, sclerosing adenosis, small duct papilloma, hyperplasia, atypical hyperplasia, carcinoma. Then the area shown as lobular stroma, from this place arises fibroadenoma and phyllodes tumor. Nipple and areola and the smooth muscle is shown by red area. Large ducts and lactiferous sinuses. Lesions arise from them is ductectasia, recurrent subareolar abscess, solitary ductal papilloma, Paget's disease. Interlobular stroma, fat necrosis, lipoma, fibrous tumors, PASH, fibromatosis and sarcoma. Clinical presentations of breast disease: pain, although almost all painful masses are benign and only about 10% of breast cancers present with pain. A palpable mass in the upper outer quadrant is more worrisome. Skin tethering, nipple inversion is seen in malignancy as more scar is produced in breast malignancy. Middle age, nodular breast lump, more likely to be the cause is fibrocystic disease of breast. Bloody pus nipple discharge, most commonly seen in inflammatory conditions or duct papilloma or in situ carcinoma of breast. Breast anomalies: polythelia, that is accessory nipples, occurs in 2% population, seen anywhere along the mammary ridge. Now the photograph shows accessory nipples which are marked with red circles. Polymastria, number of breasts are increased, commonly seen in axilla, may be associated with polythelia. Now the photograph shows breast tissues in the both axilla marked with red arrow. Amastria, it's a rare condition in which the breast tissue does not develop, may be unilateral, then consider Poland syndrome, seen in 1 in 20,000, may be due to vascular accident. In Poland syndrome, there is amastria, athelia, absent chest wall and shoulder girdle muscles, and bony anomalies of the chest. The photograph shows unilateral absence of breast tissue which is marked with red circle. Adolescence, hypertrophy of breast. There is progressive breast growth, either familial or related to obesity or hormonal disturbance, which is shown in the photograph that there is bilateral hypertrophy of breast. Tuberous breasts, it is a congenital anomaly of breast shape. The base is constricted. There is a herniation of breast tissue under enlarged areola. The photograph shows distortion in the shape of the breast. The base is constricted and there is enlargement of the breast. Breast asymmetry, it is a common presentation at the commencement of thelarchy. Vaginal or juvenile breast hypertrophy. It is a rare condition which is associated with extremely rapid growth of breast. It typically occurs in young girls who are less than 16 years of age. There is a history of rapid growth of one or both breasts to massive size. The overlying skin may show hyperemia and necrosis. It can be related to hypersensitivity of mammary tissue to estrogen stimulation that occurs during puberty. The benign findings can be confirmed on mammography during puberty. Gross morphology, diffuse process involving one or both breasts. Discrete masses are not present. Histological features characterized by proliferation of connective tissue and ductal structures. It lacks normal lobular development. Hypercellular collagenous stroma with proliferation of branching ducts are present. Now this is the photograph which shows gross appearance of virginal or juvenile breast hypertrophy. There is bilateral enlargement of the breasts. Now this is the photograph which shows microscopic features of virginal hypertrophy of breast. There is a mammary duct which is marked with white arrow surrounded by rather loose fibrous tissue which is marked with yellow arrow.